Welcome, everybody, and welcome to this session. My name is Cori LaScala. I'm the Associate Director at Wisconsin Health Literacy, and it's my pleasure to introduce our speakers today. First, we have Dr. Andrea Morrison. She's an Assistant Professor of Pediatrics at the Medical College of Wisconsin. And we also have Cori Gibson. She's a safety specialist and clinical nurse leader at the Children's Hospital of Wisconsin, and they are both co-leaders of the Health Literacy Task Force of the Children's Hospital of Wisconsin. Just a couple of announcements at the end. If you're asking questions, we just ask that you come up to the microphone because this session is being recorded and then everybody else can hear. And then also, if you're having any trouble with your evaluations, please feel free to stop and ask me or anybody else who has a green ribbon, or stop at the registration desk and we'll be happy to help you. So without further ado, please welcome our speakers.
All right. So thank you for joining our session today. We do want to take just a moment to thank our colleague Rita Higgins, who was a real contributor to this work that we're going to talk about today. She unfortunately was not able to be here with us today, but we want to give her that shout out and a thank you because we could not have done that without her contributions to this work. So we have no disclosures for this presentation. And what we're going to talk about today is really talking about the common health literacy themes we identified in some patient safety events at an academic children's hospital. We're going to talk and try to connect how an absence of attributes of a health literate organization can lead to safety events, and then really understand the potential impact of how we can use this as part of organizational data to help support health literacy. So a family misunderstands how to give their daughter her home medications and gives us a 10-time overdose. A mom returns to our emergency room because she doesn't know that she needs to unclamp her son's G-tube in order to give his nightly feedings. A grandparent doesn't know how to manage a life-threatening emergency when her grandson's trach gets plugged. So these are our reasons for change and why we are doing this work. So when we think about health literacy and safety, clear communication is really essential to ensure patients, families, and clients understand health information and care instructions to prevent misunderstandings. Many national organizations, including the Joint Commission, have recognized the importance of health literacy and communication in patient safety. Health literacy issues and ineffective communication places patients at risk for preventable harm and adverse events. So when we think about the national patient safety, really communication gaps lead to those misunderstandings about health information, care instructions that we provide, medications, and just overall plans of care. And ineffective communication is among the top 3 root causes for sentinel events. Events that are those unanticipated events that can lead to death or severe physical or psychological injury to someone. And so all of these communication failures can compromise patient safety. So few studies have tied safety events to the need for improvement of health literacy practices in an organization. Furthermore, many healthcare organizations have not fully embraced the need to identify and respond to health literacy challenges in patient safety. So when we think about health literacy, and we've heard this numerous times throughout this conference, that we need to start thinking about our role as a healthcare system. It's important to move beyond just the focus on an individual health literacy skills, but thinking about how we as healthcare systems contribute to that health literacy equation to improve health outcomes. So this is why the Institute of Medicine really developed health literate organizational attributes. They identified 10 attributes that create an environment that makes it easy for people to navigate, understand, and use information and services to take care of their health, or in pediatrics, take care of their child's health. And as you can see on this graphic here, those attributes are really that foundation of a health literate organization. So in our organization at Children's Hospital Wisconsin, we know we have opportunities to improve. Although we had made some really great strides in certain areas, we knew our overall organizational assessment score indicated the need for improvements. So we have opportunities to improve in our verbal and our spoken communication, as well as we also have opportunities for improvements in our written communications. So our Health Literacy Task Force has been leading efforts in our organization to guide our system to becoming a health literate organization. And as part of our efforts that we've been doing this for a really long time, so over 10 years we've been we're getting there, but it's taken a little bit. But we have worked to really align our work and connect it with our organizational safety, quality, and experience initiatives. And as we have been trying to prioritize our safety improvements in our organization, we realized it was not clear how health literacy really tied to our safety events. So in order to aid in this prioritization and to continue to build our case for health literacy efforts in our organization, we decided to do this project. So we decided to do a health literacy related safety event review. And we hope that this project would help us to describe the impact of health literate communications on our patient safety, as well as identify some themes to help us prioritize our health literate safety events so we can make sure that what we're doing is going to make a difference. All right, and I'm going to turn this over to Andrea now, who is going to lead us through our methods and talk a little bit more about some of our themes.
So we were thinking we would be in a tiny bit smaller room than this. So we do have some activities planned. So for this first part, before we go into the methods, there's going to be a little activity afterwards, and I want you guys to think about your organization. What sort of data do you have at your fingertips that you, maybe not your fingertips, but accessible, that you could use to build a case for health literacy at your organization? And so that's why we went forth with this project, and we want to encourage others to be able to think about and use maybe potentially some of our methods to review. You know, from examples, we use safety data, experience data, payments data, malpractice claims, education requests, so different things. So just keep that in mind as we're going through the methods, and then we'll talk at the end. So we have a process, and most hospitals have a process that enter safety events into a system-wide database. So there's a couple of limitations though, because these are self-reported. So oftentimes it's a person involved in the incident that puts it in or that recognizes the incident. The thing about these type of events though is that we don't know these occur. We have people that come back or may never show back up at our emergency department, but have had that communication-related event at home with a medication, with equipment. So we can only get those events that actually are entered into our system. And we've never actually targeted communication as being an important piece to enter into the safety event database. And so people think more about, incidences in the hospital, prolonged hospitalization, or not getting to the floor at the right time, or receiving an incorrect medication, but not necessarily those communication events. And we have few surgical safety events. There may be a few entered, but they do it in their own method. So even though they're part of our staff and part of our hospital, they do their events review in a different way. So we were fortunate to have a safety specialist that tagged events for health literacy. So going forward, we had a member of our health literacy SIG that moved into that role of that safety specialist. And so after she moved into that role, we said, hey, let's start tagging these events. So we got an additional tag entered into our patient safety database so that when she would review all of those events on the back end through the safety department, then she would tag them for health literacy. So after she had been doing that for about 9 months, then we retrospectively queried the database for all of those health literacy events, and we're presenting data from September 2017 to 2018, May 2018. All of the authors that are listed, Cori, myself, and Rita, all individually reviewed the events and looked and decided what type of event they were, including location of where it occurred, the roles that were involved in it, what type of health literacy event type we thought that was, but that was the part that was in that we were developing, so that changed over time. And then we coded them as each different attribute of a health literate organization that was involved, or if you think about it, that was missing, that allowed that safety event to occur. And then what safety event type it was, and these can be classified as different safety event types, and we'll talk about those later, and outcomes. We mainly coded those for cost so far, and we'll be going back to look at some of the other outcomes as well. So we conducted a qualitative content analysis where we individually reviewed them like we discussed and coded, and then we met as a group to discuss and end up with a final coding. So, when going through an event, it may not always be clear, and we had to mull it over between the group of us, and we came to a consensus of what we felt that health literacy event type was. And those themes emerged as we progressed with our coding. And then we had analysis of the final themes that we conducted together as a group. We used a software called NVivo that allows for qualitative analysis, or aids in qualitative analysis. So it allows you to categorize, you can move categories around. If anybody has questions about this software, we can answer some of those as well. So I just want to come and talk to you guys a little bit in the audience potentially about other avenues that you guys might have at your organization, and have a little discussion about maybe some other people could use some of those pieces of data as well. Does anyone have any thoughts about types of events or databases or information that you might have at your organization? Yeah.
We're a literacy council, and when we get requests for help in the health system, it's usually because something is wrong.
Okay.
So we do categorize what those events are.
Okay.
Some of them are pretty extreme, like I got a $30,000 bill because I didn't do right with how I was going to access the system.
So he's talking about working for a literacy council, literacy council, and then they have people who come to them and say that they had a problem when interacting with the healthcare system, potentially some catastrophic things like a $30,000 bill. So you could review that database, and you track all those events? So then you could review that database and look for some of the health literacy event themes that might be where you'd want to focus teaching for your literacy group. Okay, great. I think that's a great idea. Yeah?
Parallel to that is patient complaints.
Patient complaints,
in a
yeah.
hospital or clinic setting, and many of those, as you know, are often related to poor communication, but being able to filter for health literacy related versus somebody wasn't very nice.
Right. So health literacy related communication versus not being nice in experience events. Oh, we want to get our hands on that database. We're trying. I think that's a great idea, because then you can focus training for staff and hospital that's involved with experience around talking about those health literacy type tools that might be helpful for those. I like that. Any other thoughts? Any other ideas of data available? Yeah.
So I'm working with community organizations in Philadelphia that serve immigrants and refugees, and we're going to work with their case managers to do some time tracking around the amount of time that they spend assisting folks in navigating the healthcare system and coordinating their care, so we can report that back to hospitals and health systems in the area, so they can kind of see what's going on behind the scenes if they don't realize it's happening, to kind of get patients to appointments and into the system.
So an organization in Philadelphia that they help people navigate the healthcare system. And so they're doing time tracking of what they're doing, and then not just time, but then also kind of the item type?
I think we're going to look at case notes as well.
Case notes? Okay.
If specific issues arise.
So specific issues in the case notes. And you might think about doing that prospectively. Maybe you might get some ideas from what we have and have some buttons that are easy to click. So, because qualitative research takes a long time, which we found out. And so anything you can do to prospectively go forward with that, I think will help a lot. These are great ideas, you guys. So what did we find? We found that I know this is a tiny, teeny piece of the pie. 4% of the events were safety events that are related to health literacy. But when you think of what the types of events that go into a safety database, 4% is a lot. So just to give it some perspective of how many events there were in that 9-month period. So the main results show that our main themes around these health literacy related events are medication events, which is not surprising. We all know how important that is. Health system events that are not otherwise under medication or discharge, because all of these are really health system events. And then discharge or transition events. That Wordle, the diagram, is a word frequency diagram that you guys see on the right of your slide there. What it shows is that the larger words appeared more often in those safety events. And so that pops out right there. Medications, that's the most frequently reported word. Orders, family, home, discharge. So those words all pop out. So even though we're going to show you the results as we went through them, but even just looking at that, you can see, yes, these are the major themes of what we found in our result. Now, because this is qualitative research, I'm not going to present specific numbers or percentages, but give you an idea generally that medication events were a little over half of the events that we saw, and then the other half is made up of those other health system events and then events around discharge and transition. So how did it look with the attributes? Well, what we see in this is mainly attributes 5 through 10. So there are a few sheets floating around that you might see the health literate attributes, and we're going to come back to that also at the end. But attributes 5 through 10, meeting needs of the population, using health literacy strategies, navigating high-risk situations such as discharge or medications. So those were the events. And interestingly, when we look at our group as our health literacy task force, we've actually more focused on number 1 through 4. So the safety events are telling us, no, actually, you really need to be focusing on 5 through 10 at this point, which is, where we're going. So before we kind of go into some of the specifics, I want to point out that the information that we're giving you about safety events in no way reflects that there is something different or wrong in our hospital. These events are helpful for knowing that we have to improve, for working on these and moving forward, and should be expected at any hospital across the nation. So the type of themes that we saw are probably not surprising when we look at the error modality themes. Both verbal and written errors occurred. Probably not surprising to anybody here in the crowd. And the different communication errors were unclear communication, so not saying what actually should be done in clear, actionable terms, information that was just plain missing, who to call, when to call, and then conflicting information, like within a discharge summary, that there would be conflicting information about medications or formula or other care instructions, and then just plain incorrect information about how to do things, but were done in an incorrect way. So we're going to break this next section down by each of those themes and go into the sub-themes. So this next section is going to be on medication, we'll do health systems, and then we'll do discharge transition. In looking at the medication mistakes, the first sub-theme is just looking at that we saw a lot of mistakes that were made on admission medication reconciliation into the hospital. So unclear medication history and on admission led to this incorrect reconciliation. People didn't confirm the doses, they carried forward an old dose. The mistakes occurred both in the dose of medication, but also the timing. So things that we would see would be an error, and somebody would receive an antiarrhythmic medication twice a day instead of once a day. The dose of their seizure medication was not as high as it had been because, those phone communications that happened weren't always reflected in the medical record, so the incorrect dose got carried forward. And then, of course, there are situations where there were no known home dose. The parent wasn't able to provide that amount, and it was unclear. But the steps that were taken on our part didn't always get to getting that clear medication dose. And oftentimes these were recognized at discharge. Oh, their Prograf, which is an anti-rejection drug, is lower this whole time they've been in the hospital than it's been at home. So when they come to reconciling those medications on discharge, that's when we actually found those. Issues then moving on to written discharge. So first on admission, issues with admission, and then issues with the unclear written discharge medication instructions. So there are issues both with the dose being unclear and the medication interval being unclear. And by interval, I mean taking every 6 hours or twice a day. And so with the unclear medication dose, what we found is that there were difficulties. A lot of these came from difficulties in the EMR with putting in ranges. So drugs like insulin, where it's variable depending on how much you eat. TPN changes depending on the time or the day of the week. And then anything where we had to put in a schedule. And, we actually wean medications and increase medications a lot. So we saw these a lot with seizure medications, narcotic weans of steroid medications, weans of oxycodone was what we specifically use a lot for narcotics. And so anytime there was a changing schedule, that led to confusion and unclear medication dose. And then the medication interval being unclear would happen with things that have different medications given on different days of the week. So chemotherapy, every Monday you take this medication, or on days 5, 8, 16. So we have this variable medication schedule, and the EMR has not been flexible enough to be able to put those in. And so what the patients end up with is a very unclear medication. And remember, these all led to an error. That's why they're here. And then also increasing the dose frequencies, so going up on a medication to be more frequent. And then sometimes the medication just didn't get on there. They didn't get the dose changed correctly, they didn't get the prescription, or they didn't receive the dispensed med when we actually dispense it. And that leads to confusion because parents don't know what they're supposed to do then when they don't get those things. And then a couple other small that we saw in fewer cases were incorrect form, like getting an IV form when they should have been given an oral form, an unclear medication plan with what they're supposed to do for multiple siblings for medication, and then pharmacy plans because medications were sent to different pharmacies. Pediatrics is a special case because there are some things that we have to compound, and there are medications that the concentrations or the suspensions are only available at certain pharmacies, and so that leads to some confusion. And then there were instances of giving conflicting medication instructions. So at times, instead of using what was written on the after-visit summary, people would handwrite in the correct dose or interval. And so what they were given verbally versus what was on the paper could be different. And then just multiple different instructions of AVS, what the after-visit summary said versus what the pharmacy labeling said, what are after-visit versus their chemotherapy. They give a roadmap of what should be done on certain days, and then conflicting about dosing strategies. And then one area of medication that came out that we sort of just called out in its own column because it is a particular instance is giving immunizations in clinics. And so there were quite a few events about immunizations, and they were missing clear communication about what vaccines were being given. And that led to vaccines being given to the wrong child. Using jargon to describe a clinic procedure, such as saying, "Oh, are you here for the add-on flu clinic?" Yep, I am. And her child got a second flu shot that they didn't need because she didn't understand that jargon that we said up front at that clinic visit. And then not truly having informed consent, not making sure that we have the right person at the right time, and we didn't clearly communicate what was being given. So in brief, medication health literacy safety events that we saw showed a lack of clarity in medication plan, and both of those things happened both verbally and written, which led to a parent not understanding the medication plan and then leading to those medication safety events. So moving on to a couple of the health system or other health system related events, we saw many issues around navigation, so where we're not assisting the families with navigating our system. And so there were issues with procedures that happen in the hospital. So those could be that we give the medications here, not you, after a mom gave their home medication and they almost got 2 doses of an antiarrhythmic medication, or not understanding what it means to transfer hospital units, communication between consultants and families, and sometimes families get stuck in the middle of that. And then the clinic procedures, like using our terms for clinics, like flu clinic. Being able to navigate the home care is a big issue with navigating the healthcare system. So confusion around obtaining, troubleshooting problems with equipment, or coordinating transportation to get to medical appointments. And so these are all big things that we saw issues where we weren't providing the navigation assistance. The pharmacy system describing what it meant if you need to have a prior authorization and what you would do if a medication wasn't in stock, or helping them make sure that they understood how to obtain refills. And I'm sure it doesn't surprise people in the room, but some people don't even know what a refill is, or that means it's waiting for you to just call the pharmacy to get one. And then after visit procedures, like what they should expect, who they should call, understanding procedures about what should happen after a visit. And then we saw a few instances of this issue where our health system relied on parents. So we were relying on them for specific information rather than using our information system. So we relied on them to transmit information, such as with immunizations, where we weren't asking the patient's name and date of birth. We were saying, oh, so they were supposed to receive their flu shot, their DTaP, and this medication. And when you confirm that way, you get the wrong patient. Because we can't expect that parents are necessarily going to know all of those medications or those immunizations. And then relying on for specific medical history, especially things that we have available in our chart, Things like a programmable shunt, meaning after an MRI scan, sometimes a shunt is for kids that have extra water on their brain, they have to have it drained, and that shunt is magnetic, and so an MRI can turn it off. But we were relying on parents to tell us, does that need to be turned back on, rather than looking into our medical record to know that if it does or not, and taking appropriate procedures. And then there were several instances of us relying on a family for a handoff between teams. Rather than using our own communication methods, we wanted the parent to translate that to the other team. And also, not surprisingly, some of our health systems issues about addressing language barriers involved giving verbal information without an interpreter present, including discussion of a medical problem or hospital procedures, or giving written information without translation. And I have to say that our hospital does a fantastic job with interpreters. And so in our practice assessment, we found that as well. But we still have areas where we're slipping through the cracks on that. And so the health system events that we found were unclear communication around navigation, relying on parents to give us health information that we can find other ways, and failure to address language barriers led to this difficulty understanding the health system processes and those safety events and poor experience outcomes due to those health literacy related events. And Cori is going to finish this up with discharge.
This is my favorite topic, is discharge-related events. I did some work around discharge improvements in our organization for quite a while, so these were really near and dear to my heart. When we looked at discharge, the events that fell into the discharge and transition category, we really found there was a lot of unclear written information that was provided, whether we provided that on our after-visit summaries or on our handouts. So this included missing information or incorrect information. 40% of these events related to feeding plans, feeding schedules, and formula. So sometimes we were giving instructions that on their written information that they're supposed to be giving something through a G-tube or a feeding tube when the child was supposed to be taking something orally, and vice versa. So a lot of incorrect information provided on those. Other events included missing or incorrect information regarding follow-up appointments, contact information for home care services or specialty services, reasons to call, information related to post-visit cares, such as like asthma management plans had missing information, wound care, and just overall post-operative management. The other sub-theme that was identified in these discharge transition events was really unclear verbal teaching that was provided regarding aftercare needs. Oftentimes there was indication that there was conflicting information, whether that was different staff provided different verbal instructions. So they're like, well, which one do I follow? One person said this, another person said that. Or there was a mismatch between what was told verbally from what was provided in written form. So for these events, the verbal instructions failed to provide complete details, often missing important information regarding follow-up, when to call. One event detailed that no one had instructed that family what to do if they started having low pulse ox readings for their child, or if that child had difficulty breathing. Our verbal teaching also failed to adequately prepare families for labs and procedures, and lacked some details around what the expected course of treatment was, or around that disease state. In another instance, we had a child who needed blood bands for a procedure, and the family had the typing cross done the day prior. When they came back for that day of the procedure, mom had the blood bands in her purse, not realizing that she needed to have those stay on that child. The other theme in this category related to equipment. So oftentimes there was indication that the families were inadequately prepared to manage that equipment at home. So they either were not able to use that equipment as intended, or they were unable to troubleshoot when they had issues arose. One patient had some bilateral knee braces on to help with his legs, but when that child arrived for therapy, the therapist saw that the child had actually had them on backwards. In another instance, a child's G-tube fell out at home, and they had to do an emergency visit to an outside emergency room because they didn't have a backup G-tube. They never were given that, so then they ended up having to come back to our clinic to get that replaced. So these events really kind of suggest that there was inadequate education or instruction around how to do that equipment at home, and also about anticipating or planning for future equipment needs. So it all points across a continuum of care, no matter what, whether it was a discharge or leaving a clinic setting or, leaving our hospital, all those are considered transitions or, discharge type events. That when there's a lack of clarity around how we verbally provide instruction, the written information we provide, as well as any equipment planning, that can lead to challenges and difficulties for families to understand what they need to do regarding care, and these can result in those discharge safety events. So as part of our work, we also looked at the financial impact these events had on our organization, because money talks, and that's kind of a big thing for organizations. If we can kind of put some money to this, why we need to do this work, it might help a little bit. So we looked at the costs that were associated with the events that we did code. These included costs for additional staff time that was needed to remedy and correct those issues that were identified. We had reimbursement losses for wasted medications and services. We had costs that related to additional care, equipment, and rehospitalizations. And then the cost that was incurred related to service recovery that we needed to provide to some families, whether it's a gas card because they had to come back for an appointment or such. In addition, we looked at the safety event classification for these health literacy related safety events. And as you can see on the graph, the majority were precursor events that reached the patient and resulted in minimal harm or no detectable harm. But we'd like to also call out there were some near miss events. Our case managers do a really great job at our organization on kind of catching some of these things before they actually, reach that patient. But they are entered in our system too as those near misses, good catches. So those are the events that did not reach the patient. But there was also a few serious safety events that did reach that patient and resulted in moderate to severe harm. So in conclusion around this project, it really helped us to identify the incidents that involve poor communication should be considered as markers for possible harm. And that organizations should really think about reviewing and addressing these safety events. So there's many opportunities to really address communication-related safety events using health literate best practices. And so we're going to move into another activity. I know we're kind of spread out here, but I'm going to turn this over to Andrea because we want to do a little bit of brainstorming with everybody here so we can kind of do this work together.
So you'll see, hopefully everyone has the second sheet of paper that is a table with items on there. The items that should be on there are those that are listed on that left-hand column. So the different types of safety events as the different categories. Okay. So what we want you guys to do, since this is, we're nearly done with this conference, if you can believe that. And I'm sure everyone has learned a lot. So I want to take a few minutes, and either you can work on this alone, or it may be much better in groups of 4 or 5 of you, and come up with some thoughts about what we could do. So for an example of those mistakes that we see on medication reconciliation on admission, what are some of those health literacy best practices that can be used? What are some resources or tools that could be used to try to address that? And then what outcome measures could we measure that would actually be able to look at that? And then what attribute might we address? And you can do that for the events that we have, or if you'd like to think about some of those events that we talked about at each of your organizations and come up with, hey, one of those themes that you think exists within your data that you have that you might be able to address with those. So I'm going to give you guys about 5 minutes or so to look at this and work it as a group, and then we'll talk a little bit about some ideas together. And just to throw up a few recommended communication strategies or things that you may want to use, some of the health literacy best practices that can be used in universal precautions, maybe some of those might make it onto your list. Is there anyone that wants to kick us off by going through what they think might work?
So one thing that I tend to do with my own kids, when I'm filling out a new health form, I have a child who is medically complex, and if providers ask me, or if I'm writing out a form and it says medication history or health history, I'll write C EPIC right on there, because and I do that if I know that system uses EPIC, because then it forces that provider to go in and actually bring up a medical record from maybe a different facility. I live in rural Wisconsin, so I don't have, my child's pediatrician is not a CHW provider. So it forces her to go and look up the current record at Children's. And then everything is listed. And then I will get up and go and look at the computer screen with her and say, okay, that's current, that's not current, that's, and we go through each med together. But it's, part of it is just my being lazy and not writing everything out. And part of it is I know that that's going to be more accurate.
So the idea is that we could use our information system and interactively work with our families and patients and invite them to look at the information system and look and do that rather than trying to remember from rote memory.
Sure.
Okay. And what attribute do you think will address? Other people can help with this.
I'd say best practices and also resources and tools.
So I think, and looking at the high risk, addressing health literacy in high risk situations like number 9, with the communication about medications. Okay.
So I'm a physician and I use Epic, and I hate to tell you, but this is the dirty little secret in medicine: is medication lists are often inaccurate because it just shows what prescriptions were sent to a pharmacy. It doesn't tell you if they got picked up. Well, and that's it. But it's not as simple as just saying go look at Epic. It's bring Epic up. What you actually did was say, bring Epic up and we'll look at it together. Right. That's different, very different. So you actually did reconciliation with a list, but I would not advise someone say, just go look at Epic, because there's a good chance it's wrong. Especially when things change, like, oh, that was too much, now you're cutting the dose in half and things like that. Those are not on the medication list, and so that's where the errors happen. That's where the errors tend to happen. Mm-hmm. If someone looks at the list and says, oh, this is okay, and they don't actually do the checking with a knowledgeable person, I strongly suggest you make your own list and have it with you every single time when you have a complex regime of medications.
And is there anything that you could suggest that a clinic could do in that situation?
Well, there's a couple other, so if we encourage patients to create a list and keep track of it, or the parents, especially when it gets complex. Have your own list, and if you have a caregiver, that's part of their job, is to have a list so that you can, and have 2 of them, one that's for you and one that you hand to the provider so they have a copy of it. The other thing you can do in trying to do reconciliation, if you can't figure it out, the patient doesn't know, and there's no one at home to call or that could go home and check, is if you can find out where they get their medicines filled, you can call the pharmacy and they will be able to look the patient up. Now, if they get them filled at different pharmacies, that makes it harder, but if they get them, even then, if you can get the pharmacy where they get their medicines, the pharmacy can tell you at least what got dispensed.
And what do you think about brown bag tools, like as a clinic, asking people to bring their medications when they come to the clinic?
It's usually an eye-opening experience. Because you tell them to bring everything you put in your mouth, and so it's herbal stuff and all those things. And there's really good evidence that people don't tell the healthcare providers about all the other stuff because they're sort of afraid that they would get the tut-tut sort of thing. And if you actually convince them, I want every single thing there, you'll be surprised what you find. And you'll find old stuff that they really didn't even know about and things like that. So yeah, it's hard. You can't do it every time because it's very time consuming, but it's definitely good with people who you're not sure about and there's a complex regime. And some people are taught that if they're going to go to the hospital, they clear the table into a bag and take it with them, and that probably is a good idea because they can just do it really fast and take it when they go to the hospital.
So the AHRQ Universal Precautions Toolkit has a brown bag medication review, and they do recommend that it's something that you can promote in your setting, whatever it may be that people bring in medications. Our hospital has safety concerns about that. Of people bringing in medications to the hospital and what might happen. We're a pediatric hospital. Kids pick things up off the floor. So that they're concerned about it, but I do think the evidence does show that it can increase, not only do we know, but then it can also increase their ability to dose the medication, and you can troubleshoot together. So there's some really good studies to support that. All right, other thoughts? Yeah.
And we are not supposed to dispose of medications in the clinic,
Right.
which is a huge safety issue.
Right.
So when they bring in
Not
a brown
supposed to
bag,
dispose.
50% are old medications, some are high-risk medications.
Yep.
We're not supposed to dispose of them in clinic.
But we can tell them where to. Yep. So there are medications, for those of you who don't know, there is a website called, can anyone help me out here? Dose of Reality, I think. And that website actually it gives you information based on your zip code where you can dispense of medications. Specifically, this was developed for narcotic medications, but it is something for that. Good. Other thoughts about how we can address one of these safety events that we found, one of these sub-themes of safety events? Talked a little bit about medications, maybe equipment, or...
I mean, I think inviting people to come in and actually walk through your institution and give them, places to find and to really do that walkthrough is really eye-opening and incredibly helpful. And it also is wonderful if you can get the right people who have a lot of power in the hospital and who are very resistant to change to hear the voices of the people and to really experience what it's like. So I think that those navigation issues are huge. I think also a best practice is orienting your critical staff that are sitting at entry points in your hospital about the value of using plain language and some of these best practices. So I think that's huge. See, I don't know, resources and tools, I'm not coming up with anything on that, but other than people resources. Outcome measures, I guess, again, your safety event, reporting your experience, you'll definitely pick up on that, I think, with that, as well as the patient complaints a lot of times, too. That gets very frustrating. And then, what's the attribute? Let's see here.
7, it's the providing.
Yeah, 7, yep. Mm-hmm, yep.
Great. And I had 3 adults show up in my pediatric ER on one day last week, and I thought to myself, clearly we're not doing something right labeling. We have a really big campus, and there's all sorts of construction. The roads are changing every week. The ER entrance changed 3 years ago, and so people, one day I had 3 adults show up in my ER. I'm like, they changed something outside. I can tell the day when they changed something with the construction project. So doing a wayfinding interview, even driving, I think would be really eye-opening to the construction people. Well, I'm afraid that our time is up. And so there's one last exercise that you can do on your own, a little planning for yourself at home, maybe some of the strategies that you guys learned here, what ideas you might have for implementing. I hope that you got something out of the exercise of trying to think about safety events and how you might actually address these. And then you can take that and potentially to address them for one thing that you want to address when you get home, and think about the barriers and who might work on it and when you might want to get it done by. So thank you guys very much. We're happy to take any questions if there's any last questions. Yes, Barb. Sorry.
When you show them this data, how do people get very defensive when they see that they haven't been telling patients what they're supposed to, and how does this go?
This is a really great question. So Barb asked how it went when we told people. We presented to the medical staff quality forum last week. They didn't get it. I'm a little disappointed that I didn't do a good enough job explaining. They were like, well, aren't we expecting too much out of families? And I was like, well, that's the point. You guys need to do something about that. So I think that there were a few key pieces that they identified that where we all can work together, and that's MedRec and EMR limitations, where we have some easy next steps that I think that we can work on. And they did identify that and recognize that, and in the spirit of change understood that. But I still don't think that they get it, it's them. They think having a pharmacy tech work on MedRec is going to change the problem, and we need to work on ourselves too. Everyone needs to work on it. Yeah.
I just wanted to applaud your work. I think this is critically important for everyone to do, and when you're speaking in the language of safety, that's the language of the hospital administrations and healthcare system administrations. So that's a powerful avenue to take towards it. So strong work. I hope everyone shares information like this. I tend to think that your 4% will grow because I think a lot of the errors that happen and safety issues are just not captured in databases.
Right.
So maybe things like nurse leadership rounding tools, any kind of handoff reporting mechanisms, observation tools, things like that can help add to the data. But I suspect that as the 4% grows, we'll be able to make a better case for this because in my opinion, the Health Literate Organization task is so difficult because it involves time and effort. And those are very limited resources for people in healthcare. So we really have to make a strong case that it can have these kinds of downstream effects. So nice work.
Thank you. I appreciate that. Marianne?
In keeping with that, two thoughts. One, I'm assuming that maybe you didn't put in a story, a couple stories, your highest impact stories when you're presenting it to the medical staff.
Yeah, including the ones, we actually could present all the quotes internally. We didn't present them here, but we presented all of the quotes internally. She was wondering if it presented the impact stories, which I agree, that's really important.
And the other thing is, we were talking specifically about what your point was, I just kept thinking of a key driver diagram. So we can't just fix it with MedRec or look at EMR or whatever, but it's the electronic. How do we optimize the electronic medical record? How do we institute an annual, at least an annual or biannual brown bag review for complex patients? Tools. What kind of tools do we give to families who have complex kids or even not complex kids? The pictograms would be an example. How do we train and make sure everybody uses teach that? And how do we engage patients so that they don't have that med list with them and don't know? They say, I would be happy to look at the list of medicines in the record with you. So one thing isn't going to fix these because these are complex issues. So thinking those through and then, as you say, working slow but steady.
And just to capture that for other people, thinking about doing it in multiple ways. So you can't just address one of these problems in one way. It has to happen many different ways.
You mentioned one of your outcomes was looking at rehospitalizations from these things, and it occurred to me that actually looking at the rehospitalizations, your 30-day, when people come back, and have that be your data source instead of your safety events. I think that you'll find many more of those are related to ineffective communication than 4%.
Yeah. And that's a really good point. And we're going to be doing some readmission work. And actually, Cori's done a lot of readmission work looking at all of those 30-day rehospitalizations. And I think, I don't know if you want to add anything to that.
It was just a thought.
I think that's a great idea.
You get at the root cause, because I certainly have heard the stories of the guy who never took a drug in his life and comes in and has his heart attack and goes home on 5 different medicines, and guess what? He messed it up.
Right.
And he came back 3 days later. So I mean, it's
exactly.
just, there's anecdotes, of course, but anyway, I just thought
as
a data source, it might be richer in terms of the communication issues to look at rehospitalizations than, because you say, well, it's only 4%. I can see the hospital.
I didn't present that to them.
Yeah. Okay. They'll go, well, we got 96% to deal with. What about this 4%?
Right. Exactly.
But,
no, I didn't present that to him because I think it looks too small. Or the other one
is focus on the malpractice cases, because that's bad press, and it cost, and a lot of the malpractice cases are, how big a check would you like us to write you? And so, and there was one hospital that addressed very aggressively the consent process because that was a root cause
Where the
of
issue
a lot
was.
of it. It was communication over consent, and they saw theirs go down a lot after they seriously addressed consenting issues.
I think looking at the malpractice cases is a great idea.
Yeah.
With,
It's a smaller subset too, so it's easier to deal with.
That's one of the challenges. Organizations don't want us to look at that
Yep,
data.
we have issues trying to get that.
Yeah, but it costs them money, and it looks really bad in the newspaper. And that's what that should be the pushback is, this looks, these are preventable events.
Right.
It's often about communication, and yeah, yeah. Just
Yep, I like
keep
that.
pushing.
It's a good idea. It's a good idea. One last question, because I'm sure everyone wants to go to lunch.
I was just going to make a statement that
Yeah.
recently one of the initiatives that UW had implemented is each day the inpatient nurse managers receive information about patients on their units that have been readmitted within 30 days. And then the expectation is that they use a tailored set of interview questions to multidisciplinary approach the patient as a team with a set of questions, one of which addresses, what's changed since you left the hospital or what's different, and then one of them addresses, did you feel that you received appropriate discharge instructions when you left and knew how to care for yourself? And then we have a readmissions work group that's collating all of that information to try to find themes.
I think that's a great idea. And this is something that could be used for whatever Sentinel event at any organization that you might have, that, if anybody is coming and they're telling us that they didn't have this, that wasn't given to them from the system, then what can you do? And can you have a standardized checklist of questions? I think it's a great idea. Thank you guys so much. We appreciate